Good evening. I'm Dr. Paul Holman. I'm the Chief of the Neurosurgical Spine Service at Houston Methodist Hospital. Welcome to the Neurological Institute Education Series Spine Lectures. I'm joined by my partners, Dr. Sean Barber and Dr. Meng Huang. Dr. Huang is going to introduce our guest lecturer today.
Thank you very much, Dr. Holman, and I have the distinct pleasure of introducing one of my mentors from the University of Miami. We welcome today Dr. Mike Wang. He is the Chief of Neurosurgery at the University of Miami Hospital and the Fellowship Director of the Neurosurgical Complex and Minimally Invasive Spine Fellowship, the very fellowship that I had the pleasure of training in not too long ago. Dr. Wang is one of the most renowned and accomplished minimally invasive spine surgeons, nationally and internationally recognized, especially for his work in endoscopic spinal fusion. So we're very pleased to have Dr. Wang join us today. Thank you so much.
Thank you, Dr. Wang. It's a pleasure to be here. Houston is a fantastic place. I've had the pleasure and honor of being at your facility multiple times with Dr. Britz, and it's just a fantastic place. So thanks for putting this on. It's really very cool. So with your permission, I'll share the screen. And I guess I've been tasked with this discussion about robotics, which I think they're really cool. And, you know, this is being recorded in 2021. So I think we're at a nexus time in terms of an inflection point in terms of what's going to happen. And I've entitled this talk, Robots Are Only the Beginning. And the reason I say that is because a lot of folks who look at robots today, they say, wow, they're so limited, right? And they can't do that much. But in reality, it's just the beginning of a revolution that I think is going to happen. So I'll try to be entertaining as well as informative. This is during the pandemic times. We're about to go through wave 3, I think now in the country of America. And this is how it was originally with Zoom meetings and you know, we're falling asleep. And then very quickly we get quite adept. And here I am doing 2 Zoom meetings. And I'm sure everybody listening has done this. We've entered a sort of a Zoom era and Zoom hell, even trying to do this meeting today, which is a wonderful way to educate people, but it's complicated. So that shows the adaptation that goes on. And so here are my disclosure slides. And I would say that the more relevant disclosures would be that I do surgery like most of you, and I'm paid for that. In the right patient, surgery works. That's my belief. I want my patients to do well. I want to maximize efficiency and reduce complications. I think spine surgery is in a state that's very advanced, but still needs improvement. And I think technology is the way there. I think that is the route by which we're going to achieve better outcomes. So this is a picture of Greg Basil, one of our chief residents, soon to be faculty members. And this is a picture that was taken of him sleeping with the spine. And I'm sure Dr. Huang remembers just a couple of years ago when he was here in Miami, we would talk about this concept, like when you start dreaming about your surgeries the night before, you are really reaching a next level of concern and a good concern in terms of your commitment, right? And so I think that all the folks on this panel, certainly our hosts, share this passion in terms of the betterment of spine surgery. So let's talk about knowing where you are, because the reality is that if you think about this concept in surgery, this is really important. And I was watching the Dr. Death show that was released in NBC and had listened to the podcast. And it's very interesting because I think, you know, without editorializing, I think that illustrates well how knowing where you are is part of the problem, right? So we can go back in time to the early invention of the Chinese magnetic compass to find true north, and then the evolution of using the stars and the heavenly bodies like the sextant to try to find our way around the world. And then, of course, the geo-isocentric satellites that are positioned above us for GPS system in geosynchronous orbit. And then it develops into things like Waze, which was invented after the Loma Prieta earthquake by Israelis to guide people around the broken Freeway 5, connecting Northern and Southern California, and then onto the world of the self-driving car, which we can debate how quickly that's going to come, but I think we all agree someday that's going to come. But knowing where you are is important because, you know, we're changing bodies and we emphasize anatomic knowledge, and you know, we often think about visualization to get us oriented anatomically, right? But if you think about surgeons who are very slow in the OR, oftentimes you'd say the surgeon's lost, and being lost is a big problem inside of what we do. So here are some pictures of various robotic devices in use in neurosurgery, either cranial or spine surgery, that I took pictures of in the exhibit hall I'm not purporting that anyone's better or worse than another, but the point of the matter is this is something that's real. It's coming, right? It's coming because it's important. But a lot of people are afraid of robots for a lot of reasons, right? And here's some examples. This is from the Tesla autopilot. I think one of the first deaths occurred in northern Florida. A person was watching Game of Thrones in his Tesla and went right under a semi truck, and he was decapitated and killed almost instantaneously, right? And a pedestrian killed in Arizona. And this is from the 737 MAX, right? Crash, this whole idea about how there were several airliners that crashed because maybe it was pilot training, maybe it was the autopilot function. There are a lot of elements of this human-machine interface that deserve attention, and when it goes poorly, it goes very, very badly at times. Now, people always say, well, robots could be dangerous, like the human beings are much safer, right? And that's the discussion. But I would tell you this harkens back a long time ago. In 1979, there was a robot in an auto manufacturing plant, a Ford plant in Milwaukee, Wisconsin, that actually killed a worker. Okay, so people don't know this history, right? This goes way back. People are like, well, someday, robots will kill humans, right? It's already happened, right? It happened, 40 years ago, right? That a robot killed a human being in a manufacturing setting. People are like, well, no, but I mean like robots like in Terminator, right? Those kind of robots. And the reality is that's happened as well. Many of you remember this was in the great state of Texas. In Texas, about 5 years ago, there was a situation where there was a sniper buried in one of the buildings, and he was impossible to get to. And what the police decided to do, and this was really a sentinel event, they took one of these robots, which is actually a robot used to defuse bombs or deal with bombs, and they put a bomb on it. And they said, we're going to bring you a meal or whatever, right? And the robot comes over to this sniper, right? Of course, the robot's not going to get shot, and explodes and kills him. Okay, that is an intentional use, a militarized or law enforcement use of a robot essentially to kill a human being, right? So the future has arrived. We are not in this sort of like world of thinking about, wow, one day like it's going to happen. It's already happened, right? And of course, you can go further with this in terms of drone warfare and all that. So let's talk about robots for humane uses, right? Let's talk about robots in spinal surgery today. So, if I were to talk about neurosurgeons and robots, I would tell you should think about the CyberKnife. The CyberKnife is actually one of the few true robotic devices that actually does the entire procedure with the robot. I was at Stanford University when the visionary inventor of the CyberKnife, John Adler, came up with this concept, and it is truly an amazing concept. And of course, we use the CyberKnife regularly today in medicine, right? And so we can think about this concept of the robot, a machine that carries out these complex tasks, and then the concept of the cobot. The cobot is an assisted device, a computer-controlled assistive device. And actually, almost all the robots, except for the CyberKnife, is really a cobot, right? So this is us with the Mazor X with Stealth Edition. When we received it, some of our fellows, Tim is now faculty here on to my right, and Dr. Wong knows these guys, Jason Leonakis and James Badu, and we received one of the first Mazor X with Stealth Edition and have been using it here at University of Miami for surgeries, right? And why do we do this? Why do we take this leap of faith and this expensive capital expenditure? Because the robot does a lot of things for us. Number one is enhances accuracy and efficiency, right? So I don't think that it really would be a good use of your time for you to listen to me talk about screw accuracy with the robot, because so much has already been written about this. And this is a nice review by Paul Park from University of Michigan, looking at robots being placed. And of course, this is a bit dated because most of these are from the Mazor Renaissance, not the Mazor X, right? And then there's one paper by the Rosa. And you can see the screw placement rates are extremely high in the 90+%, some as high as 100%. But the idea is that it's at least as good as what we can do as human beings in general, if you're going to be honest about screw placement and breaches, right? So that's the accuracy, right? But what type of accuracy? Now, it's very easy to say, well, we are good at putting screws in, and certainly Paul Holman's probably put in 50,000 screws or maybe 100,000. And you think about it, you're like, okay, well, there's screws that are going into pedicles like this, and then there's screws that are going into pedicles like this, right? And so, when you think about it, you want to make it so that even the difficult sclerotic small pedicles, the atrophic ones, can still be cannulated, right? And that's what the robot does. And what about finer levels of accuracy. For example, putting the screw in so it doesn't violate the facet joint, the adjacent proximal facet joint. And that's another example of where the robot can be excellent. This is a forest plot, just looking at a couple papers showing that you can plan it out better because you can think ahead of time about how I'm going to avoid that facet rather than trying to pick the place that you think with your eyes that this might be a good place to put a screw, right? So it favors the robot, certainly. Second, the robot protects you from a lot of occupational hazards. And I know people are going to say radiation, right? Because radiation is the big deal, right? And of course, radiation is a big deal for some people. And the Asians, the East Asians, especially Chinese, hate radiation. And this is an example of Timur Yurikov using augmented reality with artificial intelligence to place screws in a lab setting. And he's really taken this a long ways. And using like the HoloLens and various types of ways of doing things accurately, so you don't need radiation with navigation type assistance. And this is important because you start to think about other things besides radiation. Here's an example of endoscopic surgery. You can see here Jason Leonakis is putting in the endoscope and exploring. On the left, he's looking at the screen in normal, which is you're looking at a display screen, a flat panel display screen. You can see how his neck is positioned. It's not so ideal. He'll probably ask for it to be moved over to the other side of the bed. Whereas Dr. Yurikov here on the right is using the HoloLens to look at the endoscopic images through his HoloLens device. So he has great ergonomics. So just that very neck positioning is an issue because a lot of surgeons, spine surgeons, need ACDF later, right? But what about this? So this is an exoskeleton device that is used commonly in the automotive industry, where this gentleman has to work underneath the chassis of a car under manufacturer. And you can imagine doing that for 8 hours a day, what that would do for your body and the strain and stress and physical exertion. Think about the strain involved in what you have to do every day, just putting screws in. If you could minimize that by putting screws in differently, that might be an amazing thing. Third, the robot can start to change the way you think about cases, okay? Now, what do I mean by this? So if you think about it, the planning software is one of the really key features of these robotic devices. In other words, you can plan everything out before you do it. Now, this is important because I know a lot of people plan. They think about screws, they even measure pedicles, they write this down on a blackboard or dry erase board in the OR, and they tell people what size screw I'm going to use, and that's all marked out. But it doesn't capture some of the detail that you can in this kind of imagery, right? So here you can see the planning of screws, the sizes, the diameters, the location, everything's done before you even execute on the surgery, and it allows you to change things up beforehand, right? And we can talk about how these devices change in terms of the ability to resist deflection or skive and things of that sort. And this video probably won't run, but the point of the matter is you can do that, right? But here's another video that allows you to, I'm sorry, it's not running for some reason, that allows you to plan and then deal with the skive potential within the robot, okay? And this basically allows you to look as you're going with the Stealth Edition to be able to see what's going to happen with the screw trajectory, right? And then it allows you to do surgeries that you might otherwise find difficult or impossible to do, right? So here's a paper we wrote a long time ago. This was published in 2017. This is about an academic experience and learning curves with the robot. And this was the idea being here that maybe the residents and fellows in our training program could use the robot as part of their assistive device, their cobot, right? And this was the take-home message. If you look here, these graphs show, for example, on the top left, PGY 1 through 5 versus PGY 6 through 8. This is speed of surgery per screw. So you can see the junior people, the junior residents are a little bit slower, but not really any different than the senior chiefs and fellows, right? That's a very compelling statement. I'm not saying they're as good as the chiefs and fellows. I'm saying that putting screws in for them is pretty much just as fast. What about whether they have experience doing spine cases? People have done less than 3 spine cases versus more than 4 cases, which is nothing, right? You should do hundreds and hundreds. And yeah, the people who have experience doing more cases are a little bit faster. You can see they're tighter in their grouping. But the reality is that it looks quite similar. The error bars overlap. If you look at people who are dedicated or not dedicated to spine surgery, so for the non-neurosurgeons listening, there are some neurosurgeons, I don't know why, who decide just to do functional or endovascular or tumor surgery in the brain. And there's some that want to do spine surgery like Dr. Wong and Dr. Holman. And so the guys who are dedicated, yeah, they're a little bit faster, tighter grouping. But the reality is not markedly different from people who have no interest or minimal interest in spine surgery. This is really compelling data in terms of what we do. So here's an example. This is John Sarak. This is in 2015, he was our chief resident then. He was a seventh year, of course, performed over 500 surgeries in residency. He's great at spine. He loves spine. He's got 2 dogs. He's married. He's got a good IQ. And over here's Greg Basil when he was an intern, and he's a chief resident now. And he had performed very few surgeries, and his first screws were actually put in with the robot, right? And I'll tell you, for John Sarak, he doesn't like the robot, right? Because he spent 7 years learning how to do spine surgery. Greg Basil loves the robot because he just steps into the OR and he's like, well, I don't know a lot about surgery, but maybe the screw part, this piece of it can be made simpler so I can focus instead on indications or the decompression or osteotomies or things of that sort, right? And I always think about it like this, like Paul Bunyan and his blue ox, the giant ox babe, versus new technology. And there's a great Disney movie about this. And, all neurosurgeons are trying to be Paul Bunyan. If you've ever been to Minneapolis or Minnesota, you could see the legend of the West of America, conquering of the West. Paul Bunyan's legendary, right? Because he was cutting down forests, right? And making houses and all this. And Paul Bunyan is amazing. He's a superhero. But compared to the chainsaw, which anybody can use, any idiot can use a chainsaw, it's important that the chainsaw took over, right? Because we all think we're the superhero. But the reality is that's not always translatable or scalable. Now, what about what I like to do, Dr. Huang and I were talking about the awake fusion earlier, and it's one of my favorite surgeries. It's a big innovation, I think, on our part, and we've really taken it very far. But a lot of people say, well, I can't do this surgery. I don't want to do this surgery because I don't have the ability. But if I had the ability, then I'd love to do it. Well, what if we took away the part of the awake anesthesia, and then we replaced it with the robot? Right? So now you've got a situation where you have accuracy and localization, you have stabilization with the screws, you can get the pain control, the X-Pro, you can distract and correct, fuse, and you can visualize with the endoscope, right? That leads to an amazing ability to do stuff that you ordinarily wouldn't be able to do. Sorry, I don't know why the videos aren't playing on this, but it's very bizarre. But anyways, this video just shows us doing robotic TLIF, and you can actually get that online, right? But there's stuff that's coming next, right? So surgeons resist change. This is a big deal. Surgeons are always resisting change. So robots are good at knowing things about, three-dimensional positioning. They can do computational tasks, repetitive tasks. They can control force beyond the dynamic range of the human body, and they're not confined by our anatomy, right? Meaning the surgeon's anatomy. Humans are good at decision-making, identifying visual landmarks, communicating, adapting to weird architectures and changes and shifting between modes. So I always think about this. This is Michael DeBakey. This is what he used to say. He goes, get an EEG to see if this resident has any sign of brain activity, and then if I had 3 hands, I wouldn't need you at all, right? So that's a typical Michael DeBakey-ism, right? Well, he's got a point, right? So you've got 2 hands. Michael DeBakey's got 2 hands, right? So you need an assistant. But what if you had 4 hands? So this is a picture of a Da Vinci robot, which is another robot making a sandwich. And what if you had 8 hands, right? What if you have 7.5 hands? What if your hands were 2 millimeters in size versus 2 meters in size? This is what robots can do that we can't do. We can't change who we are overnight anyways, maybe slowly with evolution, but we can't change ourselves very quickly, right? But the reality is that the current robots are a little bit limited, right? Because right now they're basically trajectory applying modes, right? But if you look at what an MIS TLIF does for you, right? So you've got all these steps, and I know there are more than this, but positioning, plan the incision, dissection, the Wilsey plane, the retractor placement, the decompression, the disc removal, the cage placement screws, and then rod placement and closure, right? So these are the parts of the surgery, right? So the robot can't really position for you. It might help plan an incision, it's possible. It doesn't really dissect the soft tissues. It doesn't dock your retractor. It doesn't do your decompression. It doesn't do your disc removal. It doesn't do your cage placement. It helps with the screws, and it doesn't help with the rod. So 2 out of these 9 basic steps maybe help with the robot, right? So what's coming next is the ability to do other things. And I apologize the movie's not running, but things like bone removal. This shows the Mako drilling off the bone so you can place a proper knee prosthesis for knee replacement or hemiarthroplasty, and the robot is doing that and it's guiding you with haptics, so you can really feel what's happening with the body, right? When you do that, so you can be guided in terms of bone removal. Think about what that means, right? And then this is a German company that is designing a system for drilling the translab procedure. So it's got a sensor on the tip, so you can actually drill the egg, the shell of the egg, without perforating the amniotic membrane. You may remember from your early days in a Midas Rex courses, drilling eggs, the shell off the egg without violating the egg. And here's a device for placing hair grafts, right? This is for hair transplant, right? And I'm sorry, again, the videos aren't running today, but it shows the hair implants being placed accurately, like planting crops, right? And then finally, a device for sewing heart valves, right? Sewing these valves on, right? So you could close a durotomy this way, or you could close a wound this way. So what if you could, for example, do a T-lift with these types of robots? You still couldn't position. You could plan your incision. You couldn't dissect your plane. You couldn't dock your retractor, but you could remove the bone with the Mako type robot. You could remove the disc. You could take all the soft tissue of that out. You wouldn't be able to place the cage, but now these cages are actually being placed, at least guided with robotics. You could do your screw cannulation insertion, and you still can't put your rod in, but you're much further along, and you can start to see how you can pick off these elements by having more adaptive robots. And then there's one last piece, which is allows you to practice and rehearse to get ready for the big game, the big performance. You think about what we do in surgery. It's kind of like what professional athletes or musical performers or artistic talented people like dancers do, right? And surgery is that type of physical enterprise, right? So, think about what this means in terms of what we do in surgery. So in other words, if you think about thinking about the future as being another form of memory, in other words, when we sleep, we're thinking about the future, we're working through iterations about what might happen in the future. And I'm reminded about, the role of dreams in how we adapted as humans as opposed to animals. Think about the future and plan for next days or weeks or months to survive. And I think about the movie Inception, right? It's quite important. And so, this video shows us planning screws before surgery. And here we would think about, okay, let's put it this way. And then we're like, well, maybe let's tweak it like this, see how it looks on all planes. This is not something you can really do in surgery, right? Because you have to just execute. You have to do it in your head. But here the robot lets us plan it, look at it, tweak it. We're like, those screw heads look a little too close. Let's adapt that, move it over here. Play it through your head. Say, okay, that looks like where I want to put it. Let's rehearse that, right? And then the robot executes it. So this is a very, very different type of a way of imagining surgery. But, we can always imagine in our minds, but you can imagine and visualize what will happen, right? And that's an extremely powerful tool in your toolkit for complex surgeries, right? And I think about, guys like Chris Kyle, who's a Texan, right? Chris Kyle from SEAL Team 3, and the Track Point X. This is a $20,000 sniper rifle that can then shoot someone at 1 mile. Okay, and think of all the training that went into like Chris Kyle, right? Amazing American sniper, right? And this machine can do kind of what he does, calculating wind, the gravitational field of the earth, the Coriolis effect, all these things that you kind of work into the artistry of sniping can be handled partly by a computer, at least, and some special sensors, right? Quite powerful. Think about MIS surgery. Think about how you try to plan your rods, maybe get your screws in just right. Most of the time, we're just trying to get screws in the pedicle, right? But how do you plan that out so you avoid having trouble getting rods in because you planned those screws poorly or you executed poorly on that, right? So those are all compelling reasons, right? So the next stages are quite important. Real-time visual spectrum monitoring. This will play out in the endoscope. This is the Mazor X, and behind here, you see this thing that looks like Wall-E, right? It's a very interesting device that is actually watching us and not in any weird way, but it's intended in the future to monitor our hand movements, our instruments. So if that was a 7x45 screw, if that was a number 4 Kerrison, 4mm Kerrison, this is what that can do in the future, right? This is what it's designed to do stereoscopically, right? And just be aware that this is what people are planning for the future, right? And that device, right, is really intended for those purposes, right? So improved sensing, vibration, material density sensing, electromagnetic tissue impedance sensing, right? Combining photoacoustic imaging with what we do. These are things that are going to happen, right? live ultrasound so you can know when you're about to get through bone or about to hit the dura, right? These types of things are going to be incorporated. They're senses that we don't have as humans. They need to be augmented. And the best place to put it is onto a robot. So think about this, micromanipulation. I mentioned it before. This is the hand of someone bigger than me, right? This is a smaller hand. Think about what that means in terms of what a robot can do by having precision control. And this is a funny video that I should run, which is I hope I can do it. There's Jacques Morco's clipping an aneurysm, right? And think about the kind of control of the fine motor that happens here, right? And here we have this is an orthopedic surgeon doing some kind of a operative procedure, right? And I think about this, and this is really what's going on in surgery, right? Think about the video on the left and the video on the right, and both are being done by surgeons, right, in the operating theater, maybe right next to each other, right? Think about the difference in force application that you have to control. He's worn out, right? In terms of what that means, a human dynamic range, sorry, because of the noise, the human dynamic range is limited, right? And we're also limited to mechanical force. What if you could use things like focused ultrasound, different types of force? Now you're like a superhero, right? And that would be done with robotics, right? What about the space with which to function? What about the lack of precision, right? This shows that as we work, we lose accuracy and precision because we fatigue, right? We all do, no matter how good we think we are, right? So think about all these elements of what we do, right? So what's a robot good for? Making an average surgeon better, allowing all surgeons to perform complex operations potentially someday, right? Micromanipulation, improved sensing, certainly in the future, and minimizing surgeon stress. And I like to see extending the operative lifespan of a surgeon. So, maybe you'll see surgeons who are in their 70s and 80s who have great cognition, but they're just not as good with their hands anymore. Maybe the robot will allow them to keep practicing medicine, right? So, I think about it this way. You got Dr. Huang. He's a master endoscopist. He's a much better endoscopist than I am now. And he's like the Navy SEAL. A lot of money and time and effort and sweat, blood, and tears go into his training. And then you think about the robot, and it's a little bit more like a drone. Now, I'm not saying that the drone pilot doesn't have to be expert, but the drone pilot doesn't have to exhaust themselves physically the way these guys on the left do, right? And that's where I see the future of robotics headed, right? Think about disease progression. Think about using big data analytics for disease phenotyping, then using, what we consider our current robots for the execution of a plan, then using tailored enhanced recovery processes like genetic analysis, opiate responses, addiction potential to help tailor the kind of medicines administered afterwards, then long-term management with outcomes assessment using real-time dynamic monitoring, which is something we're doing as well with cell phones and stuff with a company that we founded. So these are the exciting things. And I always think about Ed Benzel talking about a fool with a tool is still a fool. And, everybody thinks about their new tools. And this is true for robotics too. You got to know how to use the tool. You got to know how these are applied. And here's this very enthusiastic gentleman doing MIS surgery, not being able to see the other side with a nice drill. But again, we're working on human bodies, a lot of important stuff on the inside. And if you don't manage it properly, you can run into some real issues there. So shameless plug for our neurosurgery podcast, and congratulations to all you guys at Houston for putting this together. This is really fantastic. And I look forward to seeing you guys in person sometime when this pandemic clears up a little more.
Thank you, Dr. Wang. That was a great review and appraisal of where robotics has been and where it's going. The directions are obviously towards more autonomization of the actual functions of surgery. Do you see any? First of all, do you have access to more robots now than since when I was there? Are you still only limited to the Mazor X, or are you using other robots too at this point?
So we have a ROSA. We don't have the spine application yet, and we're about to get the Excelsius. So we're super excited. We now have Augmetics since you left. So we got a lot of cool toys here that we love, and I think that technology is very important. We all like to think we're master surgeons and we're true experts and we don't need any help. But as we get older, we get smarter, but we also get a little physically weaker. And so that sweet spot of when a surgeon is like a master can maybe be extended. And I'm excited to work with the other robots. I think they're all great. I think they're very exciting and they're really second generation. So we've got a long ways to go. So, I think it's an exciting time to be if you're a young surgeon or in training now.
Hey, Mike, that was an awesome talk. I have a question for you. When I talk to other surgeons about robotics, they kind of have the same opinion that you led with, that it's really, just a tool to put in screws at this point in time. Some of the South Koreans are doing biportal endoscopic surgery. When you look at the future of robotics in terms of doing bone removal, do you think we can do it with a single arm, or do you think we're going to develop more biportal systems?
Yeah, that's a great point. I love that you say that, because why limit it to 2, right? Why not have 6 ports for different things? And I think when you start to consider how anthropomorphized surgery is, the idea that our table's a certain height because the average surgeon is like this, or we use pedals, as opposed to voice control or, sensing of what we just want. You start to have your vision broaden into a whole new realm of surgery. And I don't want to get overly wonky like it's like Star Trek, because that's not what I'm suggesting. I'm just saying that we've become so accustomed to such a prefixed concept of what surgery has to be. And it's very interesting as we're all neurosurgeons, right? When you think about this concept, I'll throw one out there, like embolizing the middle meningeal artery for subdural hematomas, chronic subdurals, right? When people first brought it up, it's like, that's a crazy idea, man. Why would you ever do something like that? And you start to think about, whoa, wait a minute. They're approaching subdurals from a completely different perspective of pathophysiology than trauma or pressure. And I think that robots will give spine surgeons the option to do this. And we've never been able to do that except with osteobiologics. That is going to be a big leap in spine. And that's something we need to be prepared for, that spine surgery may change drastically, whether it's an early intervention or some kind of I don't want to get too ideological, because there's so many people that will never do like a genetic treatment of spine, or you'll never get to a non-fusion option for the disc or whatever. It doesn't really matter what you think is going to be the route for spine. When you take away our need for having to open up so big, the world changes. Let's say you could do your fusion through a 0.5 millimeter opening. I mean, think about what that would mean to healthcare. And that's where the robots come in, right? That's where the robot can do maybe something that we can't do, or in a different way. And so I think that I don't want to get overly abstract, because I agree that the robots currently are just trajectory-seeking devices or planning devices. But I think that once these get set in place, you're going to see a drastic leap, like a renaissance of what's going to happen.
Awesome. That's great. Well, Mike, we really appreciate you being here virtually in Houston. We hope to see you in person as the COVID-19 pandemic hopefully comes to an end. We know that you have a case to do. You're always busy in the OR, so we really, really enjoyed your talk and appreciate your time.
Thanks, guys. Enjoy. Congratulations on doing this. It's fantastic. I love it.
Thanks so much.
Great. Well, with that, we're going to move on to our next talk. So again, my name is Paul Holman. I'm the chief of the Neurosurgical Spine Service. And one of the things that we're really doing a lot of surgery here at Houston Methodist is for adult spinal deformity. So I wanted to give a talk today to share some of our experiences with preoperative planning and some of the new patient-specific technology that we're using in the operating room. So for any of the non-physicians that might be tuning in, I think people have this idea that scoliosis is kind of a rare problem in adults. Most people that think of scoliosis think of teenagers that have surgery. But really, if you look at the adult population, you look at the prevalence of scoliosis, which basically means you have a 10-degree curve when you're looking at somebody from the front. It's over 60% of individuals over 60 years of age, so 60 and 60. So it's a very common problem. And thankfully, most scoliosis is managed conservatively. Maybe there's really not a big clinical problem, but certainly we do see a lot of patients in the office with this problem. And so, when you look at the picture of Betty White here on the left and the right, the question is if you're going to see someone that's in their maybe 50s or 60s versus someone that's in their 70s and now 80s, we're seeing patients that live much longer. They're very healthy. They have fewer cardiac problems, and eventually spinal disease, just like other orthopedic problems, will catch up with patients. So, can we use technologies in both of these patient populations the same way to deliver the best care? So if you look at scoliosis and disability, I think the thing that's changed our outcomes over the last 10 to 15 years is really understanding what drives deformity. So now we have a great knowledge of pelvic incidence, this fixed parameter, and how pelvic incidence and lumbar lordosis interplay. And when there's a big mismatch there, obviously that causes a lot of problems. So it's really the sagittal plane that tends to drive a lot of the functional disability. And then obviously SVA and pelvic tilt as well. So in terms of doing scoliosis surgery, obviously, when I'm having a conversation with a patient, it typically comes down to this, that this is somewhat of a high risk, high reward situation. So if you look at a big meta-analysis of scoliosis, long-term major complication rates can be, around 20%. Obviously, the overall complication rate is probably higher than that, but in terms of serious complications, these are very risky surgeries. So we really have to think about how we can deliver the results that we want surgically, get patients through the surgery safely without some of these devastating or serious complications. So how can we mitigate this risk-reward issue? So number one is to understand the patient's clinical problem. So I think all of us are in the academic program here. We're teaching residents, and so every time a patient shows up in clinic that has what might be a pretty visually striking curve, that doesn't mean that they really even need surgery. There are people that have pretty significant scoliosis, but they're balanced. They don't have a major problem with pain, or they're managing the pain conservatively. So we have to really think about the patient before all the imaging. Once we start looking at patients that we know maybe need surgery, we know now that we have to think about age. So when you look at somebody's alignment, you don't want to really think about the alignment as a fixed number. You want to look at age-adjusted targets. If you're a spinal surgeon nowadays, you really have to be kind of a pseudo-endocrinologist. So one of the things that we're really paying attention to, particularly in our scoliosis patient population, is bone physiology. So when I talk to patients, it's amazing how many have never had, a 75-year-old woman. They have a great relationship with their primary care doctor, never had one DEXA scan in the last 20 years. So we're ordering more of these things. We're thinking about it. We don't want to show up in the operating room doing surgery on someone that has untreated osteoporosis. Dr. Wang talked a bit about artificial intelligence, and obviously we're gaining knowledge of outcomes and how they relate to these radiographic parameters. So we have to understand kind of what the data is telling us and how we can use that data to plan our surgeries better. And then obviously preoperative planning. Again, Dr. Wang mentioned that one of the benefits of robotics is, there are surgeons that show up to do, degenerative cases. You might think that's really not an issue, but for complex surgeries, if you're not thinking about the surgery, planning it, that's really going to really potentially lead to a bad outcome. So using some of these enabling technologies where they're having you look at scans, plan things before surgery, that gets us thinking about the operation beforehand, and that's good for the patient. And obviously we want to leverage the technology like robotics and navigation and other things that we'll talk about today. So in terms of preoperative versus intraoperative, preoperative planning, what do we do before surgery? So now we're getting the 3-foot scoliosis x-rays on all of our patients. Even if it's a degenerative patient, you really start to understand the kind of the evolution of what we call the Kirkcaldy-Willis cascade. So how the aging process of the spine leads to a period of instability and then subsequently a period of stability. So when we look at these studies, we really get information that may not change our plan in a one-level fusion, but we do sometimes see things with sagittal balance, and and we're able to consult our patients and say, you're at higher risk for having, an adjacent segment problem, and helps them to have better expectations about what, their spinal issues might be down the road even after surgery. And again, looking at these imaging tests, it helps us to understand compensatory mechanisms, choose our operative plan. Are we going to do an open deformity correction? Are we going to try to apply a minimally invasive strategy? And then intraoperatively, obviously we come in with a plan, but we have to have the tools to execute the plan, and that's where navigation and robotics are super helpful. And what we're going to focus a little bit on today is this patient-specific instrumentation. And then obviously once we correct the spine, we want to look at it and say, have we gotten the result that we planned, and look at that with some of our intraoperative technology. So this is kind of an interesting thing. Dr. Schwab is a well-known deformity surgeon that's developed some of this artificial intelligence. And basically what his data shows that about 70% of the time you get what you planned. So if you have an excellent plan where you have targeted the PI to LL mismatch, about 70% of the time you're going to have a postoperative radiograph that looks like what you planned. And if you have a bad plan, about 70% of the time you're going to have a bad outcome. So this just kind of goes back to the concept of how important preoperative planning is. And so how has this evolved over time? So Dr. Barber and Dr. Huang were probably still playing, college and high school athletics when I was cutting out the trigonometric method with little scissors during my fellowship. But obviously we've come a long way. So we do have the privilege here of using the EOS system. The gentleman that developed the EOS actually got the Nobel Prize because it really cuts down on the radiation exposure for the teenage patients. They have to get multiple radiographs to track these flexible deformities that can progress quickly over time. So we're using the EOS technology for our preoperative planning, and now we're kind of using this more comprehensive unit adaptive platform to take ourselves all the way through preoperative planning and intraoperative execution. So you can see here, this is kind of this cloud-based system where we can get our preoperative x-rays. Obviously we have a good idea as surgeons about what we want to do, but we can send these images to the unit team, and they can leverage some of the data that's been collected over thousands and thousands of patients and start giving us an idea, okay, if you do this, what are going to be the reciprocal changes, for example, in thoracic kyphosis? How are the compensatory mechanisms going to unwind, and how could that affect our correction over time? So this, again, has been something that over the past 2 to 3 years we're really becoming fond of. So everyone that does deformity surgery, obviously 5-6 years ago, this was all that was talked about at the meetings. But I think this is pretty much gospel now. We know that outcomes are driven by sagittal plane alignment, PI-LL mismatch, SVA, pelvic tilt. And it used to be, again, that we had these very generic targets. So we want our SVA to be less than 5. We want our pelvic tilt to be less than 20. PI-LL mismatch less than 10. This is a slide that I took from one of Dr. Lenke's talks. But really, if you look at what's going on now, these very vanilla alignment objectives are no longer adequate for us to really take care of patients of varying ages. So we really have to look at these age-adjusted targets. So if you look at this paper here, this is from the ISSG, and if you kind of look at how you would align someone in their 30s to 40s versus someone in their mid-60s to late 70s, you can see that if you kind of go back to that PI-LL mismatch, less than 10, or a pelvic tilt less than 20, and you start looking at the normative data, those numbers, you can really have a higher pelvic tilt, you can have a higher SVA, and that's really going to be physiologic for our older patients. So we know that if you undercorrect patients, you're going to get a worse outcome. But if you look at this study, if you overcorrect patients, there's really no clinical benefit. So you don't want to really make a 75-year-old spine look like a 55-year-old spine. And in fact, overcorrection is probably, PJK is a very complicated, issue, but there's no question that overcorrection drives a lot of our problems with PJK, especially, acute PJK. again, when we start just thinking about our deformity patients, obviously Dr. Rusli has contributed a lot to the data and the thought process, and he's kind of given us even in 2018 an updated classification system. So again, it just helps us to understand when we're looking at lordosis. I remember when I was a resident, you would look at an x-ray of the lumbar spine and the radiologist would say the patient has good lordosis. Well, we know now that if you don't really look at the whole spine, if you're not looking at those scoliosis x-rays, a lumbar lordosis number that you come up with on a lumbar MRI scan or a lumbar x-ray, it's basically kind of useless information unless you understand the whole alignment of the spine. And this I thought was also interesting. This is some recent work, again, from Dr. Lafarge and Dr. Schwab. So we know that about 70% of lordosis should come from L4 to S1. So in theory, if you're planning interbody correction from L4 to S1 on a type 1 versus a type 4 pelvic incidence, that in theory, based on Rusli's classification, that you should have a much higher amount of lordosis from L4 to S1. But Dr. Schwab's data kind of is showing now that most people really have about 35 degrees of lordosis from L4 to S1. So even if you don't do a lot of preoperative planning, if you're doing a multi-level interbody correction, either just in the lumbar spine or obviously something across the thoracolumbar junction, if you can kind of target 35 degrees from L4 to S1, it turns out that more of the variation between high pelvic incidence and low pelvic incidence is probably from L1 to L4, and that this may actually be a more constant number. So this is pretty thought-provoking, and obviously these things are going to change over time, but this is something to keep in mind. So now the issue is, we do all this preoperative planning. Can we come to the operating room and execute that plan? So Izzy Lieberman with the Texas Back Institute now was my fellowship mentor at Cleveland Clinic. And I love this saying, that we come into the operating room and we want to cut with a micrometer, but we end up using a chainsaw. So again, how do we use some of these enabling technologies to cut with more precision and deliver a more precise outcome or a more precise deformity correction in the operating room? So if you look at patient-specific implants, you can kind of think about these in two categories. One would be interbody devices, and one would be rod insertion technology or rods themselves. So if you think about it, back in the day, we used to use femoral ring allograft, and then we had PEEK, which was kind of a sexy thing when I was a fellow. And most of the ALIF cages, for instance, were 10 to 12 degrees. And then people started looking at the need for more lordosis. So we kind of had 15-degree cages. And then obviously now we have what people would consider hyperlordotics, which now are really kind of standard. I mean, I don't even think a 20-degree cage is really considered hyperlordotic anymore. So we have the ability to look at the segmental correction. How much do we need per level? How much native lordosis is in the disc? And then what interbody cage are we going to choose? And there are a few people out there now that are really looking at custom 3D printed cages. So not only in the sagittal plane, but also in the coronal plane. And what I'm going to focus a little bit more on in this talk is now these patient-specific rods. So obviously we know there are devices like Bendini where we can use computerized rod bending in the operating room at the point of care. But what if we could think about our correction and plan and make our rods before we show up into the operating room? So again, if you kind of look at this circle from the whole unit platform, preoperative analysis, and then coming into the operating room with these patient-specific implants. So the question might come to mind, or people often say, I love bending my rods. It's a fun part of the surgery. Obviously, to a certain extent, we're artists. I think, other than plastic surgery, spine surgery may be one of the surgical art forms or surgical disciplines that's truly an art form, but we do want to blend science with art. So if you look at, this was a study that was done, it was kind of a remake, if you will, but Dr. Ames kind of looked at how good are we at contouring rod? So they took 10 experienced spine surgeons and said, okay, contour a rod without a template. We want one that's 40 degrees, 60 degrees, 80 degrees, and we'll look at how consistent we are. So it turns out that we're not actually very good. If you give a surgeon a template, their ability to bend the rod is much better. But without a template, there was a tendency to overbend rods by nearly 20 degrees. So again, we talked about how if you're doing these surgeries in patients in their mid-70s, if you overcorrect patients, you're really going to drive a lot of PJK. And so if you look at this, it really looks like rod bending, or the ability to bend the rods, we need to be more precise. We need to be better because we're probably doing an inadequate job in some cases. So just to kind of bring this all together, I was just going to kind of show one of these cases where we're using this patient-specific rod technology in our practice here at Houston Methodist. So this is, kind of a fairly, moderate degenerative scoliosis. So you can see in the middle, this is our SurgiMap plan. So I still like to take my EOS x-rays, put them in my SurgiMap program, and kind of look at, again, where's the deformity, where are the compensatory mechanisms in play, get a really good idea of what I need to do to correct the patient before I kind of turn it over to the engineers that will do some of the planning for me. So you can see anything in red is out of the realm of what's normal for the patient's age. So these are all age specific ranges here. So obviously a high pelvic tilt, and the patient also has a fairly moderate coronal imbalance as well. So, I kind of have this plan, but then I take those EOS x-rays and I send them to the EOS, to the unit team via a cloud-based application. And I say, okay, I'm going to do a T10 to the pelvis. I'm going to do 2 stages, L2 to L5, lateral interbody with an L5-S1 ALIF. And then I'm going to correct from T10 to the pelvis and do as many osteotomies as I need to get the patient into their age-adjusted alignment. So the engineers will take my scan and they'll send me a text message when it's ready to look at. And then you kind of have this case simulation. So now you can look at the alignment. You can say, okay, this is kind of what I was thinking, and I approve this plan. And basically with a push of the button, you can then have that rod delivered, anywhere in the United States within a week. And if you push them hard enough, within 5 days. So again, this is really amazing kind of virtual simulation. So if you don't like what you see, you can ask them to make specific changes. One of the things that we've kind of noticed is you are planning, particularly the inner bodies, off of a scoliosis x-ray. So as you know, with a deformity, you may have 1 or 2 disc spaces where you really see a nice orthogonal view of the disc. And it's important because if you say, okay, I think I need an extra 20 or 25 degrees of lordosis, so I'm going to put a 15-degree cage in at this level, a 10-degree cage at that level. If you don't really have an idea of what the native lordosis of the disc is, you can really start to kind of compound some of the inaccuracies or the imprecision. So one of the things that I think some of the robotic planning software will help us to do, and I think it'll be integrated, particularly, Medtronic has purchased Medicrea, is using your preoperative CT scan or MRI scan. So I often do that. I really look at the sagittal CT scan to see, okay, I'm going to use a 15-degree cage at L5-S1, and I really think there's about 5 degrees of native lordosis, and so I'm going to expect a 10-degree increase in segmental lordosis. Sometimes you say, okay, I'm going to put a 15-degree cage in, and if you really think that there's, basically no lordosis of the disc, but there's really, 10 degrees, then you're going to really get 5 degrees of increased lordosis when you thought you were going to get 15, and that really, can change the shape of the rod. So again, I'm looking at this globally. More and more, again, we're looking at things other than SVA. I tend to follow Dr. Lenke's latest recommendation, where you kind of look at C2 as the global center of cranial mass. And I'm pretty happy in my older patients when I plan my surgery, look at how much reciprocal change I might get, and I want to see C2 over the midpoint of the hip axis, maybe slightly behind. So So I think that's a good kind of poor man's way of kind of looking at what kind of correction that you want. So again, you can specify the rod that you want. You use cobalt, chrome, titanium. You can order 2 rods. You can order 3 or 4 rods. Obviously, with our deformity constructs now, I think most people have shifted to using at least 3 rods, if not 4, depending on whether or not you're going to do a 3-column osteotomy. So you can see here's our preoperative and postoperative AP X-ray, so good coronal correction. And then one of the things that I think is driving the precision in driving the value of this technology is what we do is every time that we see the patient back in clinic, we're getting another scoliosis x-ray and we're loading it into the system and we're seeing how our numbers look compared to the plan. So you can see, we're pretty good here in terms of looking at the reciprocal change in thoracic kyphosis and our PI to LL mismatch. And then you can see, this is further down the road when I've gotten my 1-year postoperative CT and kind of looking at, okay, this is how much really segmental lordosis I had at each level, and then looking at what I actually got with each of the cages and kind of, looking at how well we plan these segmental corrections. And again, I think this is an area where when we use more CT-based or MRI-based fusion with the scoliosis x-rays, that we're going to get even more and more precision in the shape of our rods. And then again, you can see here's our preoperative plan with that global C2 plumb line over the hips. Here's our postoperative plan, and it's interesting if you look at the figure on the right, you can see where the patient was preoperatively in red, and then you can see where we planned to see the global correction in the middle, and then where we're at. So in this particular patient, we didn't get as much of an increase, a reciprocal increase in thoracic kyphosis as we thought, and that actually is something that's modeled. So there is an algorithm, and based on the correction that we choose, the engineers will tell you how much reciprocal increase in thoracic kyphosis you'll see. So obviously, overall, we think that this is going to be helpful in terms of trying to figure out, who's going to be at a high risk for PJK down the road. So you can see this patient did really well, and we know that when you get the sagittal alignment right, the patients do well with a nice decrease in oswestry disability score at 12 months postoperative. Some of the very experienced deformity surgeons may say, okay, this is great, but do I really need this for straightforward deformity cases? This is an example of us using the rod technology in someone with ankylosing spondylitis, where we're going to do a little bit more of a challenging upper thoracic PSO for cervical thoracic deformity. So we're using the rod technology more and more, these transitional pre-bent rods, and you can see when there's a very stiff spine and you're really just changing it at one spot, not having an inaccuracy in the shape of your rod and pulling out those lateral mass screws at the top. This is really proving to be a very useful application of this technology. And we know, looking at the data from Medicrea, that if you use these patient-specific rods, we introduce a lot of fatigue in the rod by using our French benders back and forth. So they've seen a significant reduction in rod fracture rate, particularly if you do a 3-column osteotomy by using the proprietary method of bending the rod. So it's not only the precision of the correction, but it's also potentially decreasing our chance for late rod failure several years down the road. So we're up to about 150 cases now. We're collecting all of our follow-up data. We did recently publish our initial experience in the first 20 patients, and basically we saw meaningful improvements in all the parameters that you would want to see: decreased pelvic tilt in matching our lumbar lordosis to PI-LL mismatch. But the lower slide just basically shows that there were no statistically significant differences in what we planned and what we got. So we really are seeing a nice correlation with these rods. And as you start getting more and more patients, and the company will pool data with other surgeons in your center or people across the country, we really start to look at, again, how are we doing with each of these specific parameters. And if we start correlating this to outcomes, you can really start to pick up, what is it that's driving the outcomes in, thousands and thousands of patients. And it's going to make that predictive model more meaningful down the road. For the deformity surgeons that are tuning in, again, you might think, okay, that's cool. I don't do deformity. So can I really use this patient-specific rod technology? Well, it turns out that you really can. So we know now, if you look at, there's 4 or 5 good studies out showing that even in a single level fusion, if you don't match your lumbar lordosis to PI LL mismatch, you're at 10 times greater risk for revision surgery. So I think everyone in their practice, everyone in their residency has seen that patient that shows up 2 or 3 times during your 6 or 7 year residency and keeps breaking down above the fusion. And once you start creating that deformity and you're not correcting it, you're really going to increase the risk for adjacent segment disease. And this was a nice little study that was done by Evelina Berger at the University of Colorado, kind of looking at the radius of curvature. So you can see if you're using kind of a patient-specific rod versus an industry standard, something that you pick up out of the rod and say, hey, I need a 60 millimeter rod, you can see how that radius of curvature is really different in a patient-specific rod. So a lot of the surgeons now that are using robotics saying, place your screws with intention. Well, if we really pay attention to how we place those screws, if we maybe use monoaxial screws with some of our smaller constructs and use these patient-specific rods, you can really change the lordosis and change the correction and really drive a better outcome. So again, we've learned a lot of lessons. I started using the what's called the calibration sphere. So if you don't have an EOS, that doesn't mean that you can't use this technology. But I have found that the EOS really gives me kind of the most accurate and consistent shape for my longer deformity operations. And then again, using the CT and MRI to look at the lordosis of those lumbar disc spaces where you're going to do an interbody has really helped with the correction. And then, sometimes I do these cases and you kind of start laying the rod in from distal to proximal, and the resident's like, wow, that's way off. I mean, that's not going to fit. We know that you got to loosen the spine, you got to do the osteotomies, make the spine flexible, and if you believe in the technology, you bring the spine to the rod, and like our data shows and others as well, this is very, very precise, and you are going to get the correction that you plan. So again, future directions, we're going to see more improvements in kind of predicting the reciprocal changes, help us to select our upper instrumented vertebrae, know who's at high risk for PJK, maybe do cement augmentation, do our soft tissue tethering. Maybe we don't need to do those in every case, but certainly some of this data, the artificial intelligence is going to probably alert us to those patients that are at super high risk. And obviously, I think some of this stuff is going to be integrated into our preoperative robotic planning. So with that, I'm going to turn the microphone over to Sean. Sean did a complex oncological fellowship with one of my mentors, Diego Castellan, who used to be at MD Anderson, who's now the chairman of neurosurgery at Brown. So Sean, I'll pass it over to you.
Dr. Holm, thank you very much. That was very informative. Can I ask just a question? I know you've been using the endoscope yourself a lot recently. How do you see that being incorporated into something like deformity surgery? I mean, the trend seems to be towards more minimally invasive approaches, even with deformity surgery. So how do you think that and other tools can be used in that sort of surgery?
Yeah, I think that's an excellent question. I think Dr. Wang alluded to that in his talk. I think we know about the MIS-DEF, the MIS-DEF classification. So we know now if you see something where there's a need for a 3-column osteotomy or someone that has a really, really high pelvic incidence, there are certain limitations to minimally invasive surgery, but certainly there are cases, particularly in our patients that are more medically frail, where if we get patients balanced, we don't necessarily have to have a perfect correction, and maybe we can use percutaneous instrumentation to do some of these cases. With endoscopic surgery, again, I stage most of my deformity corrections by a couple days, but I really see a day where maybe we'll do multiple stages where we could do it under general anesthesia or awake if we know that there is a specific level that needs to be decompressed because there's neurogenic claudication, or we want to do some apical release where we might do that through a transforaminal approach. And we've all seen the power of the transforaminal approach through Campbell's triangle to really get that pathology. It's a lot of times it's the SAP that subluxates into the foramen that really drives a lot of the radicular pain and deformity. So if we can do kind of a stage 1 endoscopic decompression and then get those patients up, walk them around, as patients often do, or surgeons often do after they do their stage 1 interbodies, if we know that we've gotten the leg pain solved, then maybe we're going to shift to doing a percutaneous instrumentation if we know that the interstage x-rays kind of show that with an endoscopic decompression with the interbodies that we have an acceptable global coronal and sagittal alignment.
Well, I'm talking about spine tumors today, so this topic is mainly about metastatic tumors, also just discussing briefly some aspects of primary spine tumors. So as you all probably know, tumors in the spine happen in multiple locations. There's intramedullary inside the spinal cord or intradural extramedullary, but we're talking about extradural tumors today, or epidural tumors, which the most common of those is a metastasis, if you exclude benign tumors such as hemangioma. But we see a lot of metastases here. Unfortunately, it's a very common problem. There's specific tumors that kind of have this osseous tropism that seem to go to the spine, which is breast, lung, thyroid, renal cell, prostate. There's also melanoma and hematological malignancies like lymphoma, but they're treated differently than primary spine tumors, which is sort of the other side of this topic today. Primary spine tumors are very rare, and they require a great deal of care, and taking them out, they should be taken out in en bloc or Eniking appropriate fashion. But let's just get into it here. So spinal metastases are very common. Like I said, about 20% to 40% of all people with cancer will have a spinal metastasis, and about 20% of those will become symptomatic and require surgery. So it adds up to about 150,000 people a year in the US alone that end up needing surgery for a spinal metastasis. And this is probably going to get worse over time, unfortunately. The population is growing, the median age is increasing, and people who have cancer are surviving longer due to improvements in chemotherapy and other treatment modalities. So we're going to see more and more of it. For metastases, the role of surgery is really palliation. It's helping with pain or improving neurological deficits or quality of life. It's not designed to cure in most cases, which is different than primary spine tumors, where the goal is primarily to cure. And in both cases, there's really 3 modalities. We talk about surgery, chemotherapy, and radiotherapy. And depending on the pathology, the histology of the tumor, the role of each of those is going to be a lot different. So many tumors, even now and especially historically, have been treated with radiotherapy. And the original method for this was called conventional external beam radiotherapy, which does a great job, or did a great job, with certain tumors, radiosensitive tumors. But as you see in this chart, there are a lot of tumors that don't respond well to conventional external beam radiotherapy, like renal cell carcinoma, non-small cell lung cancer, for instance. And we'll talk later about stereotactic radiotherapy, which is sort of made up for some of the differences or some of the shortcomings of conventional radiotherapy. But Lars Lexell was the visionary who sort of developed this gamma knife in 1951. And the idea is that several beams are shot at different angles around the patient, and although there's radiation going through normal tissue in different areas of the body, it's relatively small doses of radiation, but there's this hot spot of high dose of radiation that's at the sort of epicenter of all these different beams. And this led to stereotactic radiosurgery and SBRT, which can deliver very high doses of radiation to radio-resistant tumors while sparing the normal tissues nearby. So that's kind of a breakthrough in many cases, patients with spine tumors. And in fact, for a long time, people were treated only with radiation. I would say before 1970, many people just got a laminectomy if they needed spine surgery for a spine tumor. Over time, as radiotherapy technology improved, There was some debate about whether one was better than the other, and a lot of studies around that time didn't show any real difference between the laminectomy versus radiotherapy. But there was this landmark study in 2005, the Patchell study, which sort of changed the landscape of things. And what they did was looked at circumferential decompression as opposed to laminectomy. So that means you're taking pressure off the spinal cord all the way around the spinal cord rather than just dorsally, as a laminectomy would do. So this is a randomized controlled trial that compared people. All of them had metastatic epidural spinal cord compression, and half of them got circumferential decompression with radiotherapy. Half of them just got radiotherapy alone. And the study was actually stopped early because the difference was so big. 84% were walking in the surgery plus radiotherapy group compared to 57% in the radiotherapy alone group, which just goes to show what a difference circumferential decompression can do when compared to the conventional just laminectomy approach. As you can see here, laminectomy is just a dorsal decompression, but many spine tumors start in the vertebral body and expand outward from there. So a lot of the compression is often ventral. And so many times this requires a bigger surgery, a corpectomy, for instance, but the results clinically can be much better, as you see from the Patchell study. As I said, palliation is really the goal. It's not curative. Cancer is generally cured with, at least spine tumors, with chemotherapy and radiotherapy, and people are rendered NED or no evidence of disease, not by surgery, by taking out every little cell of tumor. Once the tumor is metastatic, the cat's kind of out of the bag, unfortunately, in a way. So surgery is used as a means of helping improve quality of life. There are cases of so-called oligometastatic disease where patients have one or only very few metastases where surgery may improve the oncological outcome, but I think the jury is sort of still out on that. Primary spine tumors, on the other hand, things like chordoma or Ewing sarcoma, for instance, or chondrosarcoma, surgery, well, not in the case of Ewing's, but surgery can sometimes be curative, and that's really the goal. And the whole means of achieving this is an en-bloc resection, which means wide margins, margins free of tumor tissue. And in the spine, that can be sort of tricky because there's, the spinal column, there's the spinal cord, there's nerves, which it requires sort of special means of achieving this. So there's something called the Enneking classification, which was actually developed at the orthopedic literature for like extremity tumors, but we use that same classification and a modified version of that to sort of decide where to make the cuts and how to remove a tumor en bloc from the spine. It's something called a total en bloc spondylectomy, which, as you see in the picture there below, the entire tumor, often the entire vertebral body, is taken out in one piece, which can be challenging and a little bit maybe riskier, but again, the goal is to cure, so it's a high risk, high reward sort of situation. Separation surgery is another interesting topic. The idea is that the spinal cord does not like radiation. Very low doses, such as 30 gray in a single fraction or 20 gray and 3 fractions, can lead to myelopathy or injury to the spinal cord. So when we're trying to treat tumors, radiosensitive tumors or resistant, the goal is to get them away from the spinal cord. And sometimes that can be done through relatively small operations where a patient's decompressed or the tumor is removed from the spinal cord so that it can be radiated effectively, and often stabilization with instrumentation is involved at the same time. It's just a little slide about timing of surgery. Essentially, it should be as soon as possible. There's some evidence that a week or 48 hours is one marker, and then a week is one marker. It should be as soon as possible. And patients who have higher deficits before surgery are unfortunately less likely to regain those, and patients who have deficits for longer are slightly less likely to regain those. But when we're choosing an operation, it has to do partially with where the tumor is, what the patient's symptoms are, but often circumferential decompression is the goal, as was in the Patchell study. So as I said, many of these tumors occur ventrally and expand outward from there, so in many cases a corpectomy is required. And the lumbar spine, the cauda equina, can be moved to the side and ventral tumor can be accessed that way, but in the cervical and thoracic spine you can't move the spinal cord, so often accessing ventral tissue like that requires, a little bit bigger operation, a corpectomy, infusion. In some cases, something as simple as kyphoplasty can be sufficient. If a patient has a pathological compression fracture with pain, sometimes this is the presenting sort of sign or symptom of metastatic disease, and often you can do a biopsy to sort of diagnose or get them a tissue diagnosis and do a kyphoplasty for pain control at the same time. In the future, as we're talking about minimally invasive surgery and the robot, and I think the endoscope is going to have a role, especially in the realm of separation surgery, where the goal is really just to decompress the spinal cord. Perhaps that can be done with an endoscope and maybe even without instrumentation, but it's an interesting idea that we'll have to get more into. I think we're going to start to develop an animal model here for spinal metastatic disease to see how the endoscope can work in that scenario. As Dr. Holman mentioned, bone quality is very important, especially when putting in instrumentation. Unfortunately, patients with metastatic disease often don't have good bone quality, so sometimes we augment screws with cement or polymethyl methacrylate in order to increase the stability of the fixation of the construct. Carbon fiber hardware is another sort of exciting realm of instrumentation, where the traditional titanium hardware causes a lot of artifact on MRI and on CT. So when you're watching a patient in follow-up to see if they have a recurrence, it can make it slightly more difficult. So carbon fiber hardware causes much less artifact, and so it can make it easier to watch for recurrence in patients with spine tumors. Another thing is that it may affect the radiation delivery. So titanium can sort of shield radiation dose in a way, and that's something else that we're looking at in the lab here, but that's sort of an exciting new technology. Brachytherapy is something that Dr. Bilski at Sloan Kettering has used a lot of, I know, for some tumors that are deeply involved with the dura, for instance, where there's a high risk of recurrence because the tumor cannot be completely removed at the dural interface. These flexible, like P32 plaques, can be used wrapped around the dura, and they can deliver local radiotherapy for a short period after surgery. Other exciting opportunities: robot-assisted resection. We have the Da Vinci robot, which is really designed for, or is ideal for using in cavity surgery, sort of like the abdomen or pelvis. It's not as great for the spine, but there are several papers like this one that talk about removal of a presacral schwannoma with the Da Vinci. Hopefully over time, as our robotic technology improves, we can use that perhaps along with the endoscope to have the robot be more involved in spine tumor surgery. Another thing very interesting is laser interstitial thermal therapy, which was used a lot in the brain for some time for burning, basically, parts of the brain. This can be used in epilepsy surgery or in tumor surgery, and there's some people who are using this in the spine or people with metastatic disease. Another interesting future direction, but this is just a short case I was going to present. It's a patient, a 55-year-old who presented with back pain, very healthy guy, no other real medical history, and was found to have this L4 mass, which was biopsied and proven to be a chordoma. So as we mentioned earlier, these primary spine tumors ideally removed en bloc. So in this case, it required a front-back approach where we released it initially from the back. We did a laminectomy and sort of released the nerves ventrally off the chordoma there. And we tucked these Tomita saws into the disc spaces there and got those saws out from the front and pulled them out from a retroperitoneal approach, and then removed the entire vertebral body in one piece. So this is just a short video. We've done the laminectomy and sort of skeletonized the nerves here, and now we're tucking these diamond wire saws into the disc space, sort of ventral to the nerves on both sides. We wrap the ends up into a little coil and then tuck those in, and you'll see we can go from the front and pull those out. So this is us coming in from the front. We found the saws on both ends, and you sort of using this back and forth motion to pull them through the disc space. This is the whole tumor and vertebral body all taken out in one en bloc piece, and there's the post-op scan using some carbon fiber interbody graft there, and the patient doing very well. But anyway, that's all I have. I think with that, I'm going to turn it over to Dr. Ming Huang, who's our minimally invasive endoscopy specialist.
Thank you, Sean. That was an excellent talk. I really enjoyed the part about incorporating endoscopy and robotics into tumors, especially secondary spine tumors where the goal is separation. I think that makes a lot of sense because obviously there's a lot of risk for wound issues in this type of surgery when we have a large opening in the patient, and perhaps if we can achieve endoscopic separation and percutaneous instrumentation, maybe both robotically guided and targeted, that may be even better for the patient. So I think that's an excellent point.
Yeah,
So.
I think so too. And a lot of these patients are a little bit sicker, so sometimes they can't tolerate a big open surgery. So
Yeah.
in that case, something small like this would be ideal. I think the technology maybe needs a little bit more, advancement before that's capable of doing that. But yeah.
Yeah, so before we get started with Ming's talk, I just wanted to ask you, if you look at the total percentage of consults that you're getting now for metastatic spinal disease, what percentage do you think you're participating in stereotactic planning and using completely non-operative approaches, SBRT or SRS?
Yeah, I mean, there's certain tumor size requirements and patient sort of disease status requirements for that. But yeah, it's our program here is sort of definitely building the radiation oncology team here. They have a new device called the Variant Edge, which is a special sort of stereotactic radiotherapy delivery platform that tracks patient respirations and has fancy cameras sort of throughout the suite that's supposed to reduce error down to like less than 0.5 millimeter or something like that. So it's exciting. And I would say, the ones that I'm involved in, I would say probably 20 to 30% of all consults or so, yeah. Usually we'll only operate if someone has neurological deficits, for a radio-resistant tumor. When people that have just pain or have mild deficits or mild like radicular pain, often we can treat with radiation alone, so yeah.
All right, Ming.
All right, so I'll try to go through the last portion of the talk as quickly as possible in the interest of time. I'm very excited to talk about endoscopic, and specifically for this segment, I'll just kind of focus on the lumbar spine. There's so much to talk about now with spinal endoscopy, and I'll just focus on the lumbar at this period. What we'll kind of go through is first just looking at lumbar disc disease in general, because here so far we've heard about a lot of the new and exciting technologies and certainly complex treatments of complex spinal diseases, but on the other end of the spectrum, we have very common spinal problems too, such as disc herniations that are very debilitating, benign in nature, and are very treatable. And I think over time, the way we treat this has evolved substantially, especially overseas in Europe and in Asia, where endoscopic spine surgery has been sort of gold standard for at least about 10-15 years at this point. So it's interesting that it hasn't really taken off in the US yet. So hopefully I think this talk will encourage us, especially in the US, to kind of invest more time into understanding and developing our skills in endoscopic spine surgery. So obviously, lumbar disc herniation is, and this figure is probably out of date at this point. This is coming out of an epidemiologic study from, I think, 20 years ago. It was about 1 to 2% of the population, and at this point, it's probably double, triple that, especially with some of the issues with obesity in the country. And so it's a very common problem. A disc herniation can cause direct nerve compression, or the herniated material, the nucleus pulposus, can actually drive an inflammatory response that causes radiculopathy, or more commonly known as sciatica. And this obviously can be very debilitating for patients. The natural history, of course, favors conservative treatment. If you look at the older landmark studies, the vast majority of the patients got better without surgery. And even when you look at the ones who did get surgery versus the ones who didn't get surgery, when they're about 10 years down the line, they're really doing about the same. And so obviously we know that the body can heal itself. And here's a prime example of that. This is a patient that I've recently seen, which is quite interesting. He, in April, developed acute onset severe pain in 2019, had severe right-sided sciatica. He met with a surgeon who wasn't that excited about surgery, and so the patient ultimately just kind of let it go and sort of just put up with it. And then the COVID pandemic hit, and so he really didn't want to seek any medical care, so he just really got through it. He didn't have any severe deficit or anything like that. And now here he is in June of 2021, having not had surgery. And this is just one of the more remarkable trials of conservative therapy that has worked that I've ever seen for a patient with a disc herniation that large to be broken down by the body just with the process of time. And so, with lumbar disc herniation, though, surgical intervention is definitely reasonable after you fail 6 weeks of conservative therapy. And so when we look at our evidence, one of the biggest landmark papers that we have as spine surgeons came out in JAMA in 2006, which is the Spine Patient Outcomes Research Trial, and SPORT for short, looking at treatment of disc herniations and sciatica with traditional microdiscectomy. So this was a prospective randomized controlled trial. 500 patients were enrolled, and there was 2-year follow-up. Now, interestingly enough, 40% of the surgical assigned group actually crossed over into non-operative care. They decided to not undergo surgery. And similarly, a large portion of the non-operative group were bad enough that they ultimately wanted to have surgery. So keep that in mind. But ultimately, when you look at the data, the primary outcomes, which were the body pain and physical function components of the short form health-related quality of life survey, as well as the Oswestry disability score, there was really not a big difference between the surgical and the non-operative arms. But when you look at the secondary outcomes, and specifically sciatica bothersomeness and self-perceived improvement, the patients who underwent surgery had a significantly improved values in these categories. And so when you track these patients in distant follow-up, so this was an 8-year follow-up of the SPORT trial, they showed that these measures were sustained and there wasn't any degradation of these results. So this really does show that even though the outcomes can be somewhat equivalent, the self-perceived improvement of these patients can be much better, and the recovery can be much faster if they have surgery. So obviously surgery is very reasonable. And so when you look at this in a socioeconomic and societal standpoint, this is a pretty good randomized controlled trial out of the Netherlands looking at the prolonged conservative care versus surgery and looking at the cost efficacy of these two routes. And so they randomized 283 patients, had half of them in conservative, half of them in early surgery, which is an open microdiscectomy with a 1-year follow-up. And really, not to go too deep into the data, but basically, when they looked at how much the surgery cost, obviously, patients who undergo surgery incur a higher initial cost, not just to themselves, but to the healthcare system. But then, when you look at those and compare the patients who didn't have surgery, who underwent physical therapy, things like that, the overall cost at this endpoint was the same because the ones who had surgery went back to work sooner. And so from a societal cost standpoint, doing surgery can get patients back to being productive members of the society rather than being debilitated and not at work. So it actually was in favor of surgery. So from a historical perspective, the lumbar discectomy procedure first came out of obviously the lumbar laminectomy. You have to get to the disc first, and so that's with a laminectomy. And so the very first laminectomy was described by Victor Horsley and Gowers for the resection of a spinal tumor, which was actually a meningioma back in the late 1800s after Lister's improvement of antisepsis in surgery. And so the evolution thereafter came with several surgeons who performed discectomy procedures. Initially in 1918, a surgeon by the name of Krauss performed a discectomy transdural, but this was labeled as an endochondroma, and really, who knows if this was actually a tumor or was it actually just a disc fragment, and common things being common, probably just a disc fragment. So several surgeons went through this process of decompressing the spinal canal. So for example, Cushing, a decompressed cauda equina syndrome with the idea that there may be a disc herniation. Now, interestingly, that was a negative exploration, so there was a concept of the disc slipping back into place, and that's why Cushing didn't really get credited for coming up with the microdiscectomy. Schmorl, of course, described the disc herniation after studying thousands of spines, and that's where the term disc herniation comes from. And of course, Dandy also did similar operations and described osteochondritis dissecans, but it really was Mixter and Barr back in 1932 that first described a case of a surgically treated disc herniation where the preoperative diagnosis was a disc herniation. And so they subsequently followed that into 1934 with a case series. And then our modern microdiscectomy procedure, the translaminar extradural discectomy, was developed by Love. And finally, the microdiscectomy was developed independently at the same time by Yassergill and Kaspar using an operative microscope. Of course, the advantage is that the microscope allowed a smaller incision, less blood loss, and less postoperative pain. So this eventually became the gold standard. So the issues with discectomy surgery is that some patients still develop post-laminectomy back pain that's chronic. Some patients completely fail altogether. They develop scar tissue, etc. There's a thought that a subperiosteal dissection and detaching of the muscles from the spine decreases segmental stability and causes these issues. And so overall, the goal of minimally invasive surgery, which is what we're always striving towards, is to minimize surgical trauma to the paraspinous muscles, facets, the ligamentous structures. And so back in 1997, Kevin Foley developed the microendoscopic discectomy. And so this was an interesting take on sort of a Wiltse approach to the spine, meaning using a transmuscular paramedian approach to the spine without detaching the muscles from the spine, and using a small tubular retractor, and then visualizing with an arthroscope. Now, this practice didn't really take off, I think in part because the optics of the arthroscopes were not very high at that time. The resolution was not good, and there was a higher than expected rate of durotomies and those types of complications. And so it wasn't really until 2003 where the tubular microdiscectomy really became popularized, and I think that was really just from a shifting of the optics from using an arthroscope to the actual operative microscope, and that at that point that allowed the recruitment of many other surgeons, and predominantly, of course, neurosurgeons, because we're more accustomed to using microscopes, and so that's where the tubular microdiscectomy came out of, and the early randomized controlled trials looking at tubular microdiscectomy versus the traditional microdiscectomy did show that patients ended up having less pain, opioid requirement after a transmuscular tubular approach. Now, of course, there's other studies, and this is probably one of the best randomized controlled trials, largest trials out of the Netherlands, looking at tubular microdiscectomy compared to conventional microdiscectomy. And what they found was that, how do I go back? Oh, here we go. What they found that the overall functional outcomes were exactly the same, of course, and so the tubular microdisc was not in any way inferior. The complication rates were the same, the recurrence rates were the same, but interestingly, they found that the patients with the tubular microdiscectomy actually had more back pain and more leg pain, and so this sort of kind of threw a wrench in the tubular microdiscectomy train, if you will, at the time. And so there was a thought that, well, maybe this really isn't that much better. And so later on, Kevin Foley, who did come up with the tubular microdiscectomy as well, did a nice meta-analysis of all the literature available for tubular microdiscectomy. They looked at about 7 or 8 randomized controlled trials in addition to retrospective cohort series. And what they found was that really the outcomes are similar, and there's overall not that much more pain, if you will. The postoperative back pain is about the same, and the analgesic requirements may be a little bit less, still favoring tubular microdiscectomy. So why is there that sort of discrepancy? Does it really result in less muscle injury than conventional surgery? Well, here's another randomized controlled trial that looked at that. These patients had their serum CPK checked, evaluated postoperatively in the 2 groups, and overall, it was found that there really actually wasn't that much of a difference in their serologies. And also their pre and postoperative MRIs were evaluated to look at cross-sectional area of muscle changes after the tubular approach and versus conventional. And really the amount of muscle damage was also not that different. So does it have to do with retraction or specific technique? This study looked at serology after traditional open discectomy as well as microdiscectomy, not really looking at tubular discectomy, but still their focus was looking at whether or not retraction had any effect on the postoperative serologies and the back pain. And so they had a total of 4 groups. The 2 of the groups had the retractors released for 3 minutes every 15 minutes during the surgery, and the outcome was that the serology was less in the patients who underwent surgery in which the retractor was released every 15 minutes, and those patients also had statistically significantly less back pain. So really, as you guys know, you guys are also very well versed in tubular surgery. I think maybe that has to do something with the actual intramuscular compartment pressure that you're generating by putting a tube down, right? I think in the early studies with the Caspar tube, those patients had this fascia widely split open, and that potential space developed before putting in the tubular retractor. So maybe that has to do something with it. But anyway, I think what that really tells you is that there's not a whole a big difference as far as short and long-term functional outcomes between tubular discectomy and traditional microdiscectomy. So is there something that we could do better? And so that's where I think minimally invasive or ultra minimally invasive, as some people say, endoscopic surgery comes into play. So these instruments are even smaller. The working diameter for these endoscopes is about 7.5 millimeters, basically, for the smallest scopes. And so if you think about a tube, even using a 14 millimeter tube, which is kind of the smallest tube that you can operate in, a 7.5 millimeter diameter endoscopic tube is about half that. And if we think about the volume of muscle displaced, that's a function of radius squared. So that's actually, even though it's only half of the diameter, the volume of muscle displacement and compression and compartment syndrome that you generate is actually going to be much higher. And so when we look at the historical context, interestingly, endoscopic surgery was born out of what was known as a posterolateral percutaneous nucleotomy, which was first described by Parvis Camben, who placed a 6 millimeter cannula through the triangle that now bears his name. And so at this time, this was a purely percutaneous surgery guided by image guidance, and the goal was to really just remove the posterior third of the nucleus and achieve indirect decompression. And so in his series of 136 patients, he actually had good clinical success in 72% of those patients in his retrospective case series. In 1988, Parvis Camben added the endoscope for direct visualization, but again, during that time, the endoscopic technology just was not there as far as optics. And so this really didn't catch on until much later on. Back in the 90s was when an angled lens scope was brought in to play by Mayer and Brock for dorsal visualization. Then as an iteration of that, Matthews and Ditzworth were then able to introduce the concept of foraminoscopy, actually looking in the foramen through Camden's triangle. And of course, selective discectomy via the transforaminal approach was produced in the early 2000s by Parvis Camden and also by Tony Young and Paul So. And they used more specific, purposeful, tailored scopes that had dedicated working channels and irrigation channels and things like that. And so this type of surgery, because of its minimally invasive footprint and lack of need for muscle dissection, could be done with local anesthesia and sedation. And this is really important. And then furthermore, Schubert and Hoogland in 2005 developed foraminoplasty, removing the ventral part of the superior articulating process with bone trifines or reamers, and this allowed more of an access to the lateral recess. And so finally in 2006, the next iteration of endoscopic approach to the spine was developed separately by Gun Choi and Sebastian Rutten, looking at an interlaminar approach, which is actually going back to the traditional interlaminar microscopic approach that we know, except using endoscopic percutaneous access. And of course, I have to throw in here that in 2016, Dr. Wang popularized the endoscopic T-lift in the lumbar spine. Of course, that's a little bit out of the scope of this discussion because the fusion and decompression, you can have two completely separate talks for those, but I just thought I'd mention that here. Okay, so in this first randomized controlled study looking at full endoscopic lumbar discectomy, the question is whether or not it's less invasive from an MRI standpoint in the postoperative setting, looking at the muscles and the muscle damage incurred by surgery. And so 50 patients underwent randomization, 25 into the microdiscectomy group under general anesthesia, 25 into transforaminal endoscopic group under local anesthesia, with a mean to 23-month follow-up. And the data shows that the postoperative back pain scale for the patients who underwent transforaminal endoscopic decompression was significantly less compared to those who underwent a traditional microdiscectomy. And time to mobilization, you can see, was much earlier in the endoscopic patients. And then when you look at the cross-sectional volume of muscle damage incurred, this was almost threefold difference in the T1 and T2 weighted images looking at postoperative muscle disturbances. And so VAS leg improvements were equal, but VAS back improvement and mobilization was superior in the endoscopic group. And of course, these changes obviously normalize over time, so this is an advantage early on for endoscopy that may not be really clinically relevant later on. And then looking at this study, also a relatively recent study looking at tissue damages caused by endoscopic versus traditional microdiscectomy. This is a much smaller study, only 10 in each group, a similar group, and then a 6-month follow-up. And in these patients, if you look at their overall general outcomes, the blood loss was much less, the hospital stay was much shorter, and then the wound size is much smaller. And ultimately, the functional outcomes are equivalent, they're the same. But the difference, and I'm sorry on this slide it's probably difficult to see, but basically these patients on serologic analysis in the traditional microdiscectomy group, the CRP, CPK, and interleukin-6 as markers of bioinflammatory response to the surgery were much more elevated and for a much more prolonged period of time in the traditional group. Looking at another study, the full endoscopic interlaminar versus transforaminal lumbar discectomy versus conventional microsurgical. This was one of the landmark trials from Sebastian Rutten, and I think this is an excellent trial because it also includes the interlaminar approach in addition to the transforaminal approach. In this study, all patients were done under general anesthesia, and then they had an 89% follow-up at 2 years, looking at a total of 200 patients randomized. And so in this study, The ODI and the VAS leg improvements were equal between both groups. So again, there's not any inferiority of the endoscopic approach. 12 patients suffered progressive back pain, and you can see the majority of these patients are in the traditional group, and this is statistically significant. Only 2 of the endoscopic patients developed progressive back pain versus 10 in the microdiscectomy group. Postoperative pain and medication requirements were significantly reduced in the full endoscopic group in the early term. And the mean postoperative work disability, meaning return to work, was almost 2 times shorter in the full endoscopic group. These patients went back to work a lot sooner. So this was very supportive for endoscopic decompression. Another study looking at the randomized control of transforaminal versus microdiscectomy. This is also a good study that came out in 2017. 140 patients, a reasonably large sample size, and 88% 2-year follow-up. And if you look at these patients, again, the ODI, the functional outcomes are the same. So there's no inferiority of the endoscopic approach, but the transforaminal patients obviously had less postoperative back pain. And when you look at their ultimate pain and satisfaction, the VAS of the affected leg score at 2 years was actually less in the endoscopic group than in the microdiscectomy group. So ultimately there was a little bit of an improvement, although how functionally significant that is uncertain. And patients were generally much more satisfied with the transforaminal approach. 2 of the microdiscectomy patients and 5 of the transforaminal required revision surgery. So the only downside that this paper noted was that there was a relative risk of 2.6 higher fold of needing a revision surgery if you're in the transforaminal group. Another small randomized controlled trial looking at traditional microdiscectomy versus transforaminal endoscopic. These patients, again, the overall functional outcomes are going to be basically the same. And then if you kind of look at everything together, there's a lot, there's now more and more meta-analysis being done. This is a more recent one looking at percutaneous transforaminal endoscopic discectomy versus open microdiscectomy only. There's some studies out there that incorporate microendoscopic surgery, but this is one of the ones that eliminates that, and I think that's important to note because the microendoscopic surgery is sort of like tubular surgery, essentially, when you think about it. And so in this paper, again, this is a pretty high quality meta-analysis looking at all the available randomized controlled trials, as well as a few retrospective cohorts. And basically what they found was that ultimately the results are about the same, meaning the short term and the long term, up to 2 years or so, these patients do exactly the same. So there's not any inferiority of endoscopic spine surgery. And then this is a very nice look published in JNS by Sean Barber and the Brown group, looking at the outcomes of endoscopic discectomy compared to open microdiscectomy, but also with tubular microdiscectomy. And I think this is an excellent comparison of all 3 different surgical types that we talked about. They included the vast majority of the, actually I think all of the randomized controlled trials to date at the time that this paper was written, as well as some retrospective reviews as well. Basically, the take-home message is that out of the 26 studies and 2,500 patients, the overall functional outcomes of endoscopic surgery was definitely no worse than any of the other groups. The tubular discectomy group and the open microdiscectomy group were basically equivalent. There's no difference. And when you look at endoscopic versus open, these patients had much lower blood loss, shorter length of stay, faster return to work, and slightly lower back pain after these operations. Of course, the long-term, true long-term follow-up, we don't know, but to the evidence, to the level of evidence that we have, there's definitely no inferiority of endoscopic spine surgery. So the takeaway for this talk is really that full endoscopic spine decompression for lumbar disc herniation is not inferior to the gold standard. The complication profile rate is similar or better in many of these studies. Lower CSF leak rate, lower nerve injury rate, There's decreased muscle trauma that is radiographically, serologically, and clinically evident. There's shorter length of stay. I think for all of us, when we do endoscopic spine surgery, all of our patients go home the same day. They don't even stay in the hospital, essentially. For elective radicular patients, there's a faster return to work. And another important thing to note is that transforaminal surgery can be done without general anesthesia, which helps with the recovery process. And with endoscopy, particularly transforaminal, there's a high degree of preservation of the posterior elements. And so, I mean, if you think about it with other surgical disciplines, such as the visceral disciplines, talking about natural orifice surgery, transforaminal surgery is basically natural orifice surgery in the spine, right? And we're really minimally disturbing the posterior elements, the facet capsules, the multifidus, and the longissimus muscle insertions. Very little disturbance to the structural anatomy that can predispose to long-term instability and failure. And so I think, truly the full benefits might not be realized until extended long-term follow-up, which is obviously very difficult in these studies and very expensive. But I think, if you have a younger patient that undergoes transforaminal surgery, that benefit may really be many, many, many more years of disease-free progression at their particular level or the levels above.
That was great, Ming. Thanks so much. Do you do your transforaminals awake, or you do them under general anesthesia?
That's a very difficult, I think, individual institutional problem. I think at our institution, usually, I think actually, every time I try to post a case under local anesthesia, last minute, the anesthesiologist will say, no, I don't think this is a good idea. Let's just do it under general. I think the anesthesiologists have to have a certain degree of comfort with doing a prone patient without an airway. And the vast majority of our anesthesiologists are unwilling. And even the smallest, medical comorbidities, such as, episodic, once in a while GERD, have gotten my MAC cases, canceled and converted to general. I don't know what your experience has been so far.
I try to do most of them awake, but sometimes patients are just more anxious about that, and they might not tolerate it very well. And I think, like you said, anesthesia has to be really tuned in with what they're using to get them the right level of sleepy, but still. I'm not sure how you feel about monitoring. I mean, I think using monitoring EMG free running is probably fine, but
Yeah, I think so far with the limitations that we have with anesthesia and the willingness to do these cases under local anesthesia, I haven't had any major issues with monitoring with false negatives or anything like that. So I think having monitoring is very important, and so far it has helped me out in a few cases where I've been too close to the nerve.
Okay.
So Sean, in your experience with Dr. Telfian, did you do any of the transforaminal surgery in the lateral position? Obviously, with the airway concerns, I think anesthesiologists might be a little bit more comfortable with patients in the lateral position as opposed to being prone.
Sure.
And I know Dr. Hool in Cape Cod is a big advocate of doing the transforaminal in the lateral position.
Right. No, we didn't. We did all of them prone at Brown. I'm familiar with Dr. Hool doing that. I've never actually seen one lateral myself, but it seems like it'd be a natural way of holding the instruments, etc. But no, I've no experience with that so far.
Ming, one other question for you. I think when you talk about all these studies, so the message is received that this is not inferior to the gold standard, which is good. We know that doing these surgeries in obese patients is probably a better operation because of the decreased chance for wound infection, and it really doesn't matter if the patient is obese or not. You're working at the end of your endoscope. But as you move from L5S1 to L3-4 and L2-3, do you think that the iatrogenic instability, that the studies will show down the road that a transforaminal is actually better in the upper lumbar spine?
Yeah, I absolutely think so. I think that's an excellent question. I mean, I have one patient that I hope to continue tracking who had a very large paracentral disc herniation at L1-2 with purely radicular symptoms. And I think in that particular patient, if I had done a traditional microdiscectomy and gone through a medial facetectomy, I think he's destined to fail and need a fusion at that level. Now, I'm not saying that he won't fail and still need a fusion, having undergone a transforaminal surgery, but I don't think I disturbed the normal structures very much in decompressing his nerve and healing the radicular symptoms that he had. And he's got a very active job as a mechanic, so we'll see how time holds up. But yeah, absolutely. I think the least that you disrupt the normal structures from the posterior tension band standpoint, all the muscle attachments. I mean, even just cutting off the multifidus tendons from the spinous process, I'm sure, has some sort of defunctional type of negative effect on segmental stability, right? And so I think just not doing that to the spine and preserving the facet capsule, not performing a medial facetectomy, only drilling down the ventral non-articular surface of the superior articulating process, all of that I think basically will not affect long-term stability that much, and so hopefully that isolated disc herniation will be the only problem that he has at that level. I'm sure you have seen and will continue to see anecdotes in your own practice as well as we continue to do more endoscopic surgery at this institution.
Excellent. Well, we had 4 talks today, and we hope that for the audience out there, both the neurosurgeons, orthopedic spine surgeons, and our patients that are tuning in, that you found them educational. Definitely want to thank Mang and Sean, and again, a great thank you to Dr. Wang, who is our guest speaker today, for a great talk. And this is going to be an ongoing educational platform at the Houston Methodist Neurological Institute. We're honored that the spine surgeons were the team to lead off of this program, and we will definitely be providing more content down the road with other faculty members giving talks about other aspects of spine care. So again, we want to thank our audience for tuning in, and we'll see you next time.